Hello, everyone. Welcome. Bonjour tout le monde. Thank you for joining us for our Heart and Strokes Women's Heart and Brain Health Research Webinar Series, the last in our series, Intersectionality in Action. Some housekeeping to get through before we get into our program. There are two audio options for you today. So you can join by computer audio, in which case, please make sure that your speakers are on and volume is up. Or you can call us with your phone. A phone number will be generated when you click phone call option. Just make sure that you are muted. Everyone should be muted, but in the event that you're not, please mute yourself to ensure optimal audio quality for everyone. We'll be taking questions through our question box in the GoToWebinar platform. So please be sure to send in your questions as they occur to you throughout the webinar, and we'll direct them to our moderator, who will direct them to the appropriate panelist. The session today is being recorded. So after the session, it will be uploaded to a Heart and Stroke YouTube channel, and we will circulate a link to that webinar for you to watch at your pleasure. We'll also be sending out a evaluation link. Please take the time to fill it out. It's very short. Survey results will help us evaluate the impact of this session, but it will also inform future programs like this. Importantly, today, I also want to acknowledge that this particular webinar has been made possible through an educational grant from Pfizer. So thank you to Pfizer. Now, moving on. I'm very pleased that you were able to join us today. I hope that you'll keep the conversation going beyond. Follow us on Twitter at Heart and Stroke, or use our hashtags, hashtag Heart and Stroke Science and hashtag Beat Inequity. And if you haven't yet already marked your calendar for next week's webinar, we'll be co-hosting a webinar with the HeartLife Foundation on enhancing virtual heart failure care. So make sure that you're signed up and that it's in your calendar. Now, before moving into the body of the program, I want to pause and, as always, acknowledge the land from which I am joining you today here in Ottawa. I'm a white settler on the traditional and unceded territories of the Algonquin and Anishinaabeg peoples. We're joined because of a commitment to equity and health equity in particular. So as you listen to our panelists today, I encourage you to think about what that means for you, especially on the topic that we're talking about today. And reflect on that in your personal and professional lives, wherever you may be from coast to coast to coast. I also want to acknowledge that yesterday was a National Day of Mourning to remember workers killed, injured, or suffering disease on the job in Canada. COVID has put a magnifying glass on historic and persistent inequities, many of which are playing out in our places of work. Accounting for these inequities is crucial to advancing our work. So I encourage you to also reflect on that as you listen to our experts. Now, a focus on equity and inequity is really the impetus for this project and this initiative. And for those of you who've heard this before, bear with me, and those of you who are new to it, some background. In 2016, Heart and Stroke received $5 million of funding for 5 years to contribute to new women's heart and brain health knowledge and ultimately to change policy and practice. We were also tasked with accelerating the adoption of sex and gender-based analysis and reporting for those who are in the field, but also by research funders across Canada. And we've accomplished this by funding research directly, so far 26 projects to date, but also by conducting knowledge dissemination and translation activities, such as this one, via the Women's Research Network. Next slide, please. Importantly, to guiding this work is our advisory structure. And by design, the Women's Heart and Brain Health Research Steering Committee consists of half professionals and half women with lived experience. So that's to say half researchers or clinicians and half women with lived experience who are living with heart disease and stroke and are very much experts in their own right. This multidisciplinary model ensures that those who stand to personally benefit from the research and practice changes are involved in informing this research agenda. And from a sustainability perspective, this model has now been replicated throughout all of Heart and Stroke's committees and councils. Next slide. This multidisciplinary model has also extended to the model that we have taken on with our Women's Heart and Brain Health Research Network. With a membership of about 200 strong from across the country and a few people who've joined us from abroad, we have been working to advance capacity related to this, with a common denominator being an interest in women's heart and brain health research. And the topic for today's session comes very much from the interests of our network and the expertise of our network. The goals for today's webinar are to learn about intersectionality as it relates to heart and brain health research and builds upon the progress to date in sex and gender. To hear from those with personal experience how pluralism has been addressed in their lives and in their work, and to understand the role of volunteers in driving impact. And to guide us through today's session, I am very pleased to introduce our moderator, Dr. Karin Humphries. Dr. Humphries is an associate professor in the Faculty of Medicine, Division of Cardiology at the University of British Columbia. Dr. Humphries is also the inaugural scientific director of the BC Centre for Improved Cardiovascular Health. For the last 5 years, she has served as co-chair, along with one of our panelists today, Carolyn Lavalay, of Heart and Stroke's Women's Heart and Brain Health Research Steering Committee. Her personal research focuses on two key areas: sex and gender differences in the diagnosis, treatment, and outcomes of subjects with coronary artery disease, and the use of information technology to facilitate the translation of evidence into practice. So now I am very pleased to hand things over to Dr. Humphries.
Thank you so much, Kristen. It really is a pleasure to be here today for the fourth and final session in this series. And it is really a distinct privilege and an honor to introduce three exceptional women that are going to be leading the discussions today. First is Dr. Sanya Anand, who is a professor of medicine and epidemiology at McMaster University and a senior scientist at the Population Health Research Institute. She's also a vascular medicine specialist at Hamilton Health Sciences. Dr. Anand holds the research chair in ethnic diversity and cardiovascular disease, as well as the Heart and Stroke Foundation of Ontario Michael G. DeGroote Chair in Population Health Research. Her research focuses on the environmental and genetic determinants of vascular disease in populations of varying ancestral origin, as well as women and cardiovascular disease. Dr. Anand will be followed by Dr. Shahin Jaffer, who is an internal medicine specialist in the Vancouver area and has been in clinical practice for over 25 years. Her main area of expertise are cardiovascular health, diabetes, and weight management. She's a former board member of the Heart and Stroke Foundation of BC and Yukon. She's also a member of the Knowledge Translation and Mobilization Working Group of the Canadian Women's Heart Health Alliance at the Ottawa Heart Institute. And she's the founding chair of the Women's Cardiac and Cerebrovascular Advocacy Committee of the Federation of Medical Women of Canada. Dr. Jaffer volunteers with charitable organizations, which her goal is the alleviation of global poverty through sustainable community development programs in healthcare and in education. And our final speaker today is Ms. Carolyn Lavalay. She's the president of Catalyst Communications. She's a professional with over 20 years of experience in this field and with a focus on community investment and building meaningful relationships that contribute to the prosperity and well-being of communities. In 2006, Carolyn was actually diagnosed with supraventricular tachycardia and underwent a non-invasive surgery that significantly improved her condition. For the past 5 years, I've had the privilege of serving with her as the co-chair of the Heart and Stroke Advancing Women's Heart Health and Brain Research Steering Committee, and more recently, Carolyn was named to the Heart and Stroke Foundation of Canada National Board of Directors. So with those introductions, I would like to turn this over to Dr. Anand to take away the first session. Dr. Anand.
Thank you very much, Karen, and it's a pleasure to be here. I'm sorry, due to my technology, you can't see me, but that's probably good for you. And I'm very happy to present some of my ideas, concepts, and research. So I have no disclosures for today's presentation, and we'll move on to the next slide, please. So the purpose of today, and in particular my talk, is to discuss the concept of intersectionality and some of the practical considerations for building upon sex and gender in research with some intersecting factors such as ethnicity, race, and socioeconomic status, as we may apply this to women's cardiovascular health. Next slide, please. And when we think about equity, diversity, and inclusion, sometimes called EDI, in cardiovascular care and research, we need to consider these factors from a number of planes. So how can equity and diversity issues influence our clinical practice and also our research? What does intersectionality mean? And what are some of the considerations you as researchers and clinicians should take away from today when you're building in an equity and diversity focus into your research? Next slide, please. So you may see over the course of the afternoon a number of these graphics to just kind of make the point and help conceptualize what is meant by intersectionality. And I think that this graphic taken from a working group think tank at York University is quite informative, so that you can see the kind of layers of the onion skin, if you will, with everything from at the center being the unique circumstances of power, privilege, and identity, to the very broad aspects of feminist intersectionality when we think of systems such as the political system, economic system, and other social forces. And for every ethnic racial group, these may have different levels of importance. So you can consider, if you are an Indigenous person or Indigenous researcher, it's so important to consider the Indigenous specific determinants of health and intersectionality of these factors in research. Next slide, please. Now, I often like to show this because it paints quite a dramatic contrast. This is the same individual from Afghanistan, Sharbat Gula, who was first highlighted by a National Geographic photographer at age 12. And then he went back to Afghanistan and found her using retinal technology to match the original retina. And, at age 12, her presentation is just so dramatic as a young individual with, almost a sign of fright in her eyes. And then, at age 30, they're seeing, obviously a dramatic change in her appearance, although the eyes are the same. And in this short course of her life, she had experienced so much, as you could imagine, including, being captured, being held in a type of refugee camp, marrying young, having children at a young age, and having chronic illness by age 30 years. And so although she's aged 30 years, she may have actually biologically aged beyond that. And so this helps make the point of the huge impact that social factors have on our health. And this concept was coined by an anthropologist in the United States. It's called weathering. So depending on our life circumstances, be it our place, our income, our education, and other exposures, we can, rapidly weather or more slowly weather. And certainly when we think of it, intersectionality and look at the groups who suffer the most, it really often points to the intersectionality of women who live in poverty and women of color in particular. Next slide, please. Now, this is the triangle that we often use to kind of show how these factors may intersect. And for example, if you were an economist and you were studying a given population, you really wanted to understand the impact of poverty on some sort of outcome, and it could be a health outcome. Your natural tendency is to divide the population by low socioeconomic status. That could be low income versus high income. But you may actually fail to consider some important variation in sex and gender and ethnicity and race. And so while you may conclude that poverty is the main driving factor, in fact, there may be an important role of gender, there may be an important role of ethnicity, racial status. And therefore, whenever you start out in research, again, we will always say defining the question is key, but one must consider how some of these social and biological factors intersect and interact. And certainly, again, to emphasize in our research in Canada and globally, women who live in poverty and women of color often have the worst health outcomes. Next slide, please. In some of my own work studying various ancestral origin populations in Canada, we examined how some of these factors of ethnicity or ancestry intersect with sex as well as social disadvantage. And here you see some data from the study of health assessment and risk in ethnic groups, otherwise known as SHARE, in which we randomly recruited people of European origin, summarized as EU, South Asian origin, people originate from the Indian subcontinent, Chinese origin, and indigenous peoples. And we show here that there is variation between sex, so men shown in blue and women in black, as well as variation by ethnicity in terms of the social disadvantage that people suffer. And in the social disadvantage index, we include measures of income, marital status, and employment. And the higher your score, the greater social disadvantage you suffer. And you can see that there's a graded increase in social disadvantage across the different populations included in this study, and this is adjusted for age. If we go to the next slide, you will see how this relationship between social disadvantage and cardiovascular risk plays out. So as we increase social disadvantage, the risk of cardiovascular disease goes up for everyone. But you might have begun this research thinking, well, men have a higher cardiovascular risk than women. But when we separate the groups out based on ethnicity and sex, you can see the highest risk group for the same given social disadvantage are men who are indigenous origin or South Asian. The second highest group, it's not, as you may expect, men from the other ethnic groups. In fact, indigenous women and South Asian women have a higher risk than European origin men or Chinese origin men. So this gives you an example that you can't just look on one dimension, sex, for example, without considering other factors such as social disadvantage and ethnicity. Next slide, please. Now, this is an example of a study which moves more towards fairness in our system or health equity. And it was a really well done study published in the New England Journal, likely more than 10 years ago, where they took individuals based on sex and race, and they gave them the identical cardiovascular risk. And they showed these video presentations of the participants here, the actors, describing their symptoms, their risk factors, etc. And they played these videos for physicians and asked the physicians, which of these people would you refer for cardiac catheterization? And what they observed were they were less likely to refer women or Black patients for cardiac cath. And if you click on the next point of the slide, I think we'll see the filling in. So that's the less likely to refer women. And if you click once more, again, less likely to refer Black men and more likely to refer a white man. And all of these individuals have the same cardiovascular risk. And if we go to the next click, and one more, we'll see that it's really the group that had the identical risk who were less likely to be chosen for referral for cardiac cath were Black women. And this interaction was significant. And when you compare the odds of being referred, if you're a white man compared to a Black woman, as I mentioned, it's much lower for Black women. So this gives you an example of how even in our healthcare system, certain biases we have towards individual based on appearance and also based on gender can influence our clinical practice. Next slide, please. Now, one of my heroes in the field of health equity is Camara Phyllis Jones, and she paints a very important picture when we try and think about health equity, and really shows that this is called the cliff analogy. So if you're the orange stick figures at the, toward the back of the diagram, you are the best off in society. You're far away from the cliff. You do have access to preventive health care and likely are relatively wealthy. And if you happen to fall ill, you can see there's a fence at the edge of the cliff that helps prevent you from falling over the cliff. If you happen to get really sick and require ambulance service to take you to the hospital, there is an ambulance waiting to take you to hospital. On the other hand, are individuals who are less privileged and more vulnerable. And especially in COVID times, this has really shone a light on the most vulnerable in our population. These vulnerable populations do not have preventive health care or a fence to protect them from falling over the cliff. And they're more likely to fall over the cliff. When they do, there may not be an ambulance there ready to rush them to hospital. And what's also not shown here is once they get to hospital, some groups face systemic racism in the hospital and therefore either don't get timely care or are turned away. Next slide, please. If we could go to the next slide, please. There we go. So I want to spend a couple minutes before I wrap up. Oh, there's one back, talking about randomized controlled trials. And randomized controlled trials, are kind of the holy grail of determining whether an intervention is effective or not. And it has been long observed that women are underrepresented in clinical trials of cardiovascular disease. And to address this, the NIH developed a policy in 1994 where they said investigators who receive NIH funding must actively work to enroll at least 50% of their trial population are required to be women. And with this kind of rule, the percentage of women in clinical trials did rise significantly. In Canada, the CIHR in 2000 put a checkbox in place where CIHR applicants had to say whether they were investigating both sex and gender-related factors in research, and if not, why not? And you're probably all familiar with filling out this component. And in 2011, the FDA released a draft guideline recommending sex-specific analyses and calling for more women in clinical trials. Next slide, please. Now, when we kind of quantify, do we have enough women in our cardiovascular trials? One useful metric is called participant to prevalence ratio, and this is shown on the left-hand side of the screen. And essentially, you look at the prevalence of the condition in the population in women, and then you look at the proportion of women included into a given trial, and you calculate a ratio. And a ratio of 1.0 means you're doing a good job. You've got enough women in your trial that proportionally represents women in your community, country, etc., that have that condition. So you can see for high cholesterol, we've had more than enough women enrolled into cholesterol lowering agent trials. but for diabetes, heart failure, stable coronary disease, and acute coronary syndrome, we are below 1.0, and that's a signal that we need to work harder to enroll women in randomized trials. So these are metrics that you can use for assessing, are there enough women in trials, as well as people based on ethnicity, race. Next slide, please. So when we think about these considerations of sex and gender, ethnicity, race, socioeconomic status, and then think about the research we're about to undertake, as everyone here will agree, spending a lot of time clearly defining your research question is so important, rather than quickly writing it down and developing methods. Understanding and spending the time and consulting with other people to get the question right is so important. And then the next question should be, how could ethnicity, sex and gender, socioeconomic status influence your study hypothesis, shape your objective, or influence the interpretation of the data you may generate? And that's important to do up front, not at the end. And we have so many examples where it's often an afterthought to, let's say, do a subgroup analysis by ethnicity, race, or by sex. And when that happens, sometimes you have limited data to reliably address that question. And sometimes the data can be outright misleading, as we've seen with some subgroup analyses of randomized trials, where there were just too few people of certain ethnic racial groups or women to develop robust subgroup analyses, and they have led to holding back certain effective therapies from women and people of color. And again, an upfront consideration should be, do you have people from the representative groups as patients with lived experience involved in your research, or community representatives who you cross-validate? Is this question I'm about to ask and research, is it of importance to your community? And I would say, in my working with First Nations people, although I might think that, you know, controlling blood pressure should be the #1 health concern, when I meet with the community, they will tell me all of the other health challenges, economic challenges, clean drinking water challenges that they may face, and they may not prioritize the same questions that you do in the academy. So that's very important to have these conversations early on. And then, as I mentioned, more and more our granting agencies are asking us to do this, but certainly we do learn so much from consulting with people or patients with lived experience and building their perspectives into our research. And I use the example of long COVID because it's, you know, we're realizing there is such a syndrome as long-term symptoms of COVID-19. And we also need to hear from the communities that are hardest hit by COVID-19, which are often our ethno-racial communities, to understand what they're experiencing so that we can design the right research to address what's important for them. So I think that's my last slide, and I'm looking forward to the panel discussion. Well, close to my last slide, but there you have it. Thank you very much.
Thank you so much, Sonia, for a really inspiring and informative talk. And at this point, I would like to turn it over to Dr. Jaffer.
Thank you to the Heart and Stroke Foundation for inviting me to present today. I hope that people tuned in across the country are all experiencing some spring weather. I want to first acknowledge and recognize my relative privilege. This is rather complex. I want to share that my experiences are privileged with regards to my education and economic status, but underprivileged with regards to my race and gender. Next slide, please. These are my disclosures, my work in research as outlined below, and also I have had full editorial control over the content of this presentation. Next slide. So this next slide summarizes my social location. I am a cisgender woman of South Asian ancestry, a Shia Ismaili Muslim, and a specialist physician. Over the next 10 minutes, I will share my lived experience, and in the latter half, I will tie in my cultural identity with some insights and proposals on how to improve research, not only in women's cardiovascular health, but all health research. Next slide. So this slide is a map of the world comprised of dried tea leaves forming the continents. I just love my masala chai. I was born in Nairobi, Kenya, as a fourth-generation South Asian. My great-grandparents immigrated to East Africa, which is Kenya, Uganda, Tanzania, from the area of Kutch and Gujarat in Western India. As some of you may know, much of Africa was under colonial rule. The elementary school I attended was comprised of mostly white and a few Black and few brown students. In the early 1970s, due to political and economic instability, my family immigrated to Canada. Here we experienced discrimination. I recall being attacked with racial slurs in high school, and raw eggs were thrown at windows at my house. On another occasion, my front door was kicked in and damaged by teenagers in the neighborhood. In my career as an internal medicine specialist, I have on occasion had patients request to see another doctor as I attended to them in the emergency department, as I was, in quotation marks, not from Canada. I must be very clear, though, that although these experiences have had an impact on me, they cannot be compared, because of my privilege, to the adverse health outcomes, including death, that Black, Indigenous, and people of color face every day due to racism. Next slide, please. So with that background about myself then, how do I see the research world from the lens of my own experience? Firstly, as I continue to learn and better understand the world around me, I realized that the benefits of a pluralistic society, its morals, ethics, and values, need to be embedded in our curricula, from early childhood education to post-secondary and beyond. Pluralism is a learned ethic. It is not innate. And we must learn not to simply tolerate differences, but embrace them as well. And I've demonstrated this concept with inviting pictures, as you can see, of various types of peppers, pumpkins, and maple leaves. The dialogue about diversity and pluralism must also prevail in our workplaces and our professional lives and continue throughout our lifespan. And as the concepts of ethics, dignity, and respect for others become entrenched, we can call upon our critical thinking and problem-solving skills to command inclusivity in the research arena. Next slide, please. So yes, and as the picture on the top right indicates, the patriarchy is not going to smash itself. We must all work together to overhaul and rebuild a broken system. So in addition to recruitment of BIPOC subjects for clinical trials, all of these groups outlined here, research project developers, decision-making and ethics boards, steering committees, principal investigators, supervisors, i.e. the leadership, must include Indigenous and racialized groups to balance the power equation. Indeed, the local and central review boards, the institutional review boards or independent ethics committees, as they are also known, must ensure that the subjects entered into the trials are sufficiently representative such that the results can be generalizable to all others. Taking into account, of course, the scope and objectives of the research, this would mean a dedicated percentage of participants would be required to be female, male, BIPOC, and from the 2S LGBTQIA+ community. And enrollment would not be closed until these criteria are met, forcing recruiters to work hard to reach these targets, to achieve these targets in a timely fashion. This principle would apply not just to government-funded studies, but ubiquitously to pharma and other industry, private research centers, and not-for-profit organizations as well. Next slide, please. As has been reviewed earlier so eloquently by Dr. Anand, it is not only socioeconomic status and sex/gender, but race and ethnicity also play a key role in determining health outcomes. And granting agencies like the CIHR and the Heart and Stroke Foundation have made good progress over the last few years with the development of sex/gender-based inclusion and analysis requirements. However, there is a critical need and a call, in fact, for a Racism and Ethnicity Institute to support research on the effects of racism on health. Next slide, please. So how about community involvement? Canada's research infrastructure has been described by some as inefficient. Beyond tertiary and quaternary hospitals, the development of community research centers, meaningful engagement of community healthcare professionals, scientists, and other community stakeholders will provide greater opportunities and numbers for women, Indigenous, and racialized people to contribute and be counted in research endeavors. Statistical power, so to speak. So in fact, there exists an abundance of potential diverse participation from the community, and as I have demonstrated in this vibrant picture of many different types of glass marbles. Next slide, please. Last but certainly not the least, there needs to be continuous oversight and accountability in research. So how do we monitor? Steering committees and IRB responsibilities may be considered as one example, but there are other unique and independent tools available. For example, the Global Center for Pluralism in Ottawa, www.pluralism.ca, has developed a validated action-oriented monitoring tool to measure inclusionary and exclusionary practices in society. This tool can be utilized not only for governments, but also for corporations, universities, and civil society organizations. In the context of research, this tool can address gaps in how protocols are making their enrollment choices, thus leading to improvements in the inclusivity and quality of healthcare research. Next slide, please. To summarize, my experiences as a South Asian woman of color, and as I've described in my social location, have taught me that pluralism is an ethic that honors human diversity and is well worth fighting for. This value system must become entrenched in research policy and practice. We all belong. We must all be respected and respect others in turn. We need diversity, differences, and yes, even disagreements, because that is how we get stronger, by working with, listening, and learning from each other. The foundation of any research should be equality in participation and engagement at all levels. Let us thoroughly and collaboratively center the voices of people who have been historically excluded. Let us become uncomfortable. It is not simple nor easy, but this deed must be done, for it is, after all, our common humanity. Thank you.
Thank you so much, Dr. Jaffer. That was really impressive. At this point, I would like to welcome Ms. Carolyn Lavalay.
Hello, everyone. Thank you, Dr. Humphries. Today I will be discussing the importance of communications, being a communicator myself, and the importance also of involving people with lived experience in preparing the communications, the messages that we want to convey. And I will be a little bit more specific as I move forward. In terms of disclosures, I don't have any disclosures to declare. So a little bit about my background, and Dr. Humphries did talk about it a little bit at the beginning. So in 2006, I was diagnosed with supraventricular tachycardia. That's always a long one to say. Thankfully, within 3 months, I underwent catheter ablation, which pretty much fixed my health issue and truly improved my quality of life and brought me quite a lot of peace, because it's quite stressful when these events occur. So I got my life back and could go back to doing what it is that I love, to be active, to train for marathons and triathlons. And thanks to the prevention programs, awareness programs, and the research that Heart and Stroke and all of you, many of you, make possible, I got my life back and wanted to give back. So I became a volunteer for Heart and Stroke in 2012. I have been a spokesperson since then, participated in many Feats for Heart challenges. I was also involved as a committee member of the Montreal Caring's Heart Dinner, because I wanted to celebrate the financial impact of donors on the work that Heart and Stroke leads. And I was particularly interested in the disparity that exists for women with cardiovascular disease. And this has led me to join as co-chair of the Heart and Stroke Women's Heart and Brain Health Research Steering Committee, together with Dr. Humphries. So I've been thrilled to see all the progress that has been achieved over the years through the Women's Initiative, actually over the last 5 years. And recently, very recently, I've joined the National Board of Directors. It has been, and it still is, a true pleasure to volunteer for Heart and Stroke, because I know and see that my voice matters and I can truly contribute to making a difference. And I have to say that this is extremely gratifying. Now, let's talk about volunteering, people with lived experience, and communication. So there's definitely a lot to be learned from Heart and Stroke's approach to engagement with people with lived experience. And it's important that other organizations also improve their effectiveness and relevance for the people who stand to benefit, whether lived experience, prevention, research programs, by involving these individuals and communities from the beginning. It's important to tailor the message to the audience that we are talking to, so that it makes sense for them and for the groups that they represent. So involving people with lived experience on our work is crucial. This ensures that everyone has the same understanding, the same view of what is actually needed and relevant for a specific audience, group, or community. And this is especially true for volunteers. Next slide, please. Why is it especially true for volunteers? Well, volunteers, and I will speak from my own experience, volunteers can have a lot in informing the direct volunteer for. We help shape some of the programs, campaigns, communications, and perhaps even some of the research programs. And if there's a specific direction that an organization wants to go, they need to involve people with lived experience of all kinds upfront, and including economic diversity, gender diversity, ethnic diversity, to name just a few. So to really make a difference for a target audience, because we talk about target audiences in communication. So to really make a difference for a target audience, you need a targeted partnership first. The message needs to start with those communities in mind so that the message is clear, relevant, meaningful, and engaging. Again, no matter what type of initiative, campaign, or communication we want to put forward. However, not everyone everyone who should be involved in informing our work will want to come to the table. It's not always the case. So meaningful engagement with volunteers will require multiple avenues for participation and input. It may be, yes, at the board level, but it could be in other forms as well. So identifying the right partners, the right gatekeepers to open doors and build trust and credibility is an important first step. A simple invitation to participate may not be sufficient. So your research or program must authentically demonstrate a commitment to integrating and elevating the expertise and issues that are of concern with and for those who have been historically excluded. Critically meaningful engagement means that people have influence on informing a decision. So leaders, researchers, and organizations should be prepared to act upon the recommendations that they have sought. So you have the right people involved. You've listened to their advice and actively involve them in the work. Without a tailored approach, you will have missed out on whole segments of population, many of whom bear the greatest burden of disease. Now, if the right individuals are involved in helping to shape programs to make sure they are relevant, they will then be able to help shape the messages so that there is optimal uptake, engagement, and participation in the programs. This may be as simple as understanding what language should be used, what terminology, where groups access and consume information, and who are trusted individuals within the communities to champion that uptake. Importantly, also consider what you deem to be commonplace in your message. What is commonplace to you may not be for others. As frequently used symbol in healthcare world is the word battle. This may not have the same impact that you would expect for everyone. Likewise, it's essential that when working with communities to elevate expertise as Heart and Stroke has done with people with lived experience. Communities that bear a disproportionate burden of disease may currently experience worse health outcomes, but they should not be considered to be in a deficit position because they too bring expertise to their health and health realities. Thank you.
Thank you so much, Carolyn. I really enjoyed that. And thank you to all three of you for really an outstanding series of 3 talks. At this point, we have the opportunity to engage in questions, and we already have quite a few questions coming in from our listeners. Sonia, I wonder if I could start with you. This is actually an interesting question. As you know, if we were to define in public health research our cohort as men, women, so addressing gender, and then allow for the other category, the question is, how do we handle that other category? Because frequently it's much smaller, obviously, than men and women. So the question here is it common practice to remove those in the other gender group as outliers, or do you actually include them? So I'm guessing, Sonia, you've had experience with this issue. Could you share your thoughts with us?
Yes, I'd be happy to. And again, I think it comes back to, what is the question of your research, and then how did you collect the data? And so, if you're analyzing a cohort study, maybe started 20 years ago, you may not have a question on gender. You might just have male, female. In fact, most cohort studies, that's all you would find. Now, in modern times, I guess this era, and as I'm setting up a couple of new studies addressing COVID right now, we ask more than one question. So we would ask, your sex at birth and your self-identified gender identity. And so I think that, again, we will have better data in contemporary studies to examine questions of sex as well as gender. And gender, depending on how it's collected, could be across a spectrum of gender. And, I think it's up to the researcher and the team, depending on what the question is. So, if it's a question that's clearly just based on biology and you want to look at a male-female difference, you may just use that variable. But if it's anything that involves, the individuals in the population, you'll likely want to use your gender variable. And that can kind of be a contrast from, let's say, genomics research, where you often will just do a sex differentiation versus, clinical or population health, where gender and gender identity may have a real impact.
Great. Thank you very much for that. Dr. Jaffer, I'm going to turn to you for the next question, though both you and Dr. Anand addressed this issue, and I thought Dr. Anand's slides laid it out really nicely, how we have been challenged to ensure that we enroll enough women in our randomized controlled trials. We've really struggled for a long time. Have you any ideas on how we can increase the number of women in clinical trials?
Yeah, sure. Thanks, Dr. Humphries. This question may have been asked just before my presentation. I did, and I'll expand some more. I did try to address this particular question, and I think where I'm coming from is, as I have worked and done research in the community setting, that's where I would suggest that we focus a lot of our interest on. There's a ton of, I guess, you could say, number of patients, whether it's women or those of different ethnicities in the community. And if we could improve our infrastructure and involve civil society, which is really sometimes described as the third sector of society, separate from government and business. If we could involve, other advocacy groups as we try to recruit physicians' offices, like family practice offices, women's organizations, those types of agencies, where I think if we just improved our description of what we're trying to do in our research, I'm sure we would find enough women who are interested, and particularly lived experience groups would certainly help us increase our numbers and participation.
Great, thank you very much. I guess let's extend this a little bit now to not just clinical trials, but as you pointed out, Dr. Jaffer, I think it's important to have this representation on steering committees, on advisory boards, and to Carolyn's point, how do we communicate with these marginalized groups to ensure that they do become engaged? I think I'd open this up to all three of you for comment. It's not just clinical trial enrollment. It's really the entire focus of the research infrastructure, if you will, from top to bottom. So thoughts, sure, if you will.
Yeah, I could jump in there first, if you don't mind, Shahin. And yeah, it's a great question, and I have these discussions at many different tables. So I'll just describe a few of them. One is, let's say, as a clinical trialist in cardiovascular disease. I've been at meetings where a group of women clinical trialists would say, how come we are so few, and how come pharma does not seek us out? And there are multiple reasons for that. It's, within your institution, perhaps, women are not advanced in leadership roles, so that they don't often become the PI of a trial. It could also be the individual pharmaceutical companies. I work with a number of them, which are very male-based and male-dominated, and I look at their tables and they have maybe one or two women. So, there's a problem on both ends of that in clinical trials. In our population studies, I think we're being forced to realize we have to get out of our ivory tower and think that we know what's best and we can just design the study, take it to the community and say, okay, we're ready to start. And certainly that's been a learning process for me over 25 years. And now, you know, I may come up with an idea, they may come up with an idea. So it's bi-directional. They may come to me, which has definitely been happening more recently, especially with my First Nations partner, with an idea, and I say, okay, let's work on it. Or I could go to them, but I need to go to them and engage them early on. Quick example would be one of the studies I'm designing now is a long COVID study, as I mentioned, and I had traditionally worked with people of South Asian origin, the Chinese community, and First Nations, but not with the Black community. And so, you know, clearly they are a high risk group in COVID and should be included. And here I am with no links, right? So what do I have to do? I have to form those links and those partnerships. And we've done that, and we need each other. They want to participate in studies, and I want to be inclusive, but I don't have the relationships with the communities. So it's making those relationships. So I think we have to really look at the entire population and say, you know, who are the most vulnerable, who need to be at the table, recognize it's more work to be inclusive. It usually costs more money, and it will take longer to do your studies. And in my world, sometimes people say, well, we need to recruit and finish by 6 months. There's no way we can include these other communities. But the hurry to get things done is actually a barrier to inclusiveness, and that's across all sectors.
Excellent, thank you. Any comments from Dr. Jaffer or Carolyn?
Yes, if I may, I would love to comment on what Dr. Anand just shared. I have to agree. I do believe, of course, I have a bias as a communicator. I do believe that two-way communication, that co-creating, co-developing programs, campaigns, and whatnot is, I believe, what will lead to the best outcomes. And as Dr. Anand mentioned, she indicated, you know, we should not remain in our ivory towers. We need to reach out to the communities. But I also think that it is a shared responsibility. It is also, I think, the community's responsibility and people with lived experiences responsibility also to reach out, to raise their hands. I can appreciate and understand that they might not necessarily know on what door to knock, but they can start perhaps with their own health professionals. And I'm hopeful that with all the efforts that Heart and Stroke puts forward in raising awareness about the existence of the organization and the various information sources they have, that this is one way also to help the community reach out as well and raise their hands.
Excellent, thank you very much. Well, I'm afraid we're running out of time. Or Dr. Jaffer, did you want to make a very quick comment?
Yes, I agree. I mean, we have to work from the bottom up, grassroots, and not just from top down, and really focus on cultural competency and cultural safety as well.
Excellent, great. Again, thank you to all of you for an excellent, excellent presentation. Kristen?
Yeah.
Thank you so much, Dr. Humphries, and thank you to all of our panelists. That was really wonderful. Next slide, Pam. So just a quick reminder to everyone to please save the date for next week if you've not already, to join us for this webinar that we are co-hosting in the spirit of partnerships with HeartLife on enhancing virtual heart failure care. And to conclude, I just want to thank you all for your time, for your continued efforts to drive this agenda forward. It is going to take all of us. I am very grateful for all of your work and your partnership. So thank you. Merci, miigwech. Be well.
Thank you. Bye for now.
Thank you.